Pledge of allegiance.
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
The Mark Twain Healthcare District mission statement is, through community collaboration, we serve as the stewards of a community health system that ensures our residents have the dignity of access to care, that provides high quality, professional, and compassionate health care. So we're going to go ahead and call the meeting to order. Roll call. Lynn Reed. Here. Ken McIntyre. Dr. Smart.
Here.
Ann Radford. Susan Atkinson. Here. And do I have a motion to approve the agenda?
So moved.
Second. All those in favor say aye.
Aye.
Motion carries. Do we have any public comment on matters not listed on the agenda? 3-minute limit each, please. Nobody wants to
Ask
talk.
Monty if I take a picture.
Loves the word. Okay, tonight our meeting is about having a community presentation, and this is the first in the series of 3. So we're really excited that everybody came. Thank you so much for giving up your time to do that this evening. Hope you can join us for the next 2 town hall meetings that we're going to have as well. And the 3 of us are going to sit in the audience, and I'll introduce Damon Doss, who's going to share information for the rest of the evening.
Thank you very much. Give you guys a chance to.
This is all one we're on.
It feels like I'm at a Oakland A's game. It's wall-to-wall people with lots of spaces in between. But we did fill the room, or at least we're wall-to-wall. And the other thing that's kind of odd is I'm going to be talking about the history of the Mark Twain Healthcare District, its relationship with the Mark Twain Medical Center, and a series of other providers, St. Joseph, Stockton, Catholic Healthcare West, and Dignity. And there are actually people in this room who actually live that history. And so they know a lot more about it than I do. And I may call upon them, so prepare yourself. You know who you are. You were here during that whole time. So I may call upon you to embellish or give your view of what happened. But we're just going to talk a little bit about how this all came to be. And there is, in the back of the room, an article is called Los Calaveras, Mark Twain St. Joseph Hospital, celebrating 50 years and more of healthcare in Calaveras County, written by Bonnie Miller. I don't know Bonnie Miller. Some of you may very well know her, but this is what it looks like. And I would encourage you to pick one up. It's very good reading. I learned a lot of a little of the nuances. I've actually been to the old Utica Hospital that's in Angels Camp, or the building, and there's some stuff left over from the Utica Hospital at the Angels Camp Museum. And they have a room now that they're dedicated to healthcare in Calaveras County, and they're working on that, so I think that might be interesting to some of you. And isn't it a shame that they tore down the old hospital? What a beautiful building it was. I've seen pictures, Nikki showed me a picture that's in the archives a year or so ago of this magnificent farm, ranch, country home over on the hills on the side over here by the government center. I think around where the library is now, somewhere in that area. But it had gardens, and it had a TV ward, and it was an amazingly beautiful building. And I guess it just deteriorated to the point that they felt they needed to tear it down. They sold it for a ridiculously small amount. It was essentially the debris, whatever the developer could salvage, and they tore it down in a very short time. But it was a magnificent looking building. Mr. Hamilton, you're not going anywhere, are you?
No, not at all. I was just going to take a picture.
Okay.
I was going to try to get the wall-to-wall picture.
Mr. Hamilton from the Pine Tree, he's here tonight videoing this event. so that we can put it on our website. And speaking of our website, most of what we're going to be talking about today or tonight comes from the website. It's information that we try to build and create an educational format for the community so they can understand a little bit about one of the most complex healthcare deals in California. And it truly is, because of the relationships that were created in this contract and the way they came together and how they survived 26 years. Amazingly, 26 years and I know that there was no controversy. I know there were controversies, but relatively small controversy. Over the time, I see a lot of the clients I work with. I work primarily in Northern California, but pretty much exclusively with healthcare districts. And the amount of controversy that in some of those places is amazing. And the confrontation and legal fights. You've had relatively little of that. And so, it's an interesting deal. It's a challenge to grip and really understand exactly what is the deal. So we're going to try and delve into that tonight. It looks like I lost something there. Come on, here we go. So evidently if I don't move this around once in a while. So we're going to take a look at that, what that deal's all about. 1946, healthcare district law was coming in. It was hospital law at the time. People were coming back from the war, World War II, and they had been satisfied with a certain level of health care, rural areas. But, you know, how are you going to, how's that song going? How are you going to keep them down on the farm after they've seen poverty? Well, when people were drafted and joined and went to other parts of the world and country, they saw health care in a different way. And they believed that they deserved that same level or a higher level of health care on a rural basis. So in the mid-40s, there was an explosion of new ideas about how to bring health care to rural areas, which we luckily still are. And so there was healthcare district law and special district law was created, a mechanism wherein you created essentially a small mini government within a certain geographical boundary that would allow you to tax yourselves and or be eligible for both state and federal funding, and that's a real important piece. The tax piece is critical, no question about it, but the real access was federal and state funding that you could get because you were a special district. So in the mid-40s and late 40s, well, that's not what we want, that's Cuba. I was there a month ago. In the late 40s, mid to late 40s, all across California, over 70 healthcare districts were formed. About 50 of them are still functioning today. And of that 50, about 30 are running hospitals, and they're called hospital healthcare districts. The other 20 or so are called community-based healthcare districts, and they primarily are serving the community as a whole, not necessarily owning or operating a hospital. We, however, are one of the ones in between those two groups. We're a hybrid in which the Mark Twain Healthcare District does not operate Mark Twain Medical Center, but we own the building and grounds. Many of the districts who no longer operate their hospital have sold the building and grounds, but we own them still. The healthcare district owns the parcel. We lease operations. We lease the operations of the hospital to the Mark Twain, now called the Mark Twain Medical Center Corporation Board. Used to be Mark Twain St. Joseph Board, I think, in the very beginning. So that's kind of a little perspective of where we sit in all those healthcare districts. Now, many of the healthcare districts who are independent have either sold their hospital or get some kind of ongoing revenue back from the proprietor of the hospital. And in some cases, they have absolutely nothing to do with the hospital at all in today's world. It's completely gone to another entity, and they're providing other types of healthcare delivery, mostly health education or they contract directly for services. We do a little bit of that, and I'll circle back to that later on. The Mark Twain Healthcare District does contract for services. So we're, like I say, continuation of that whole theme of us being a hybrid. I'll bring this down just a little bit. Here's a little bit about our history. We had a special election in August 27, 1946, in which the healthcare district was formed. Once the district was voted on by the voters, and there's another sheet I'll go to later, I won't go to that right now, I don't think it's on this one. The vote was like 1,100 yes, 70 no, or something like that. A relatively small number of people voted. There were a relatively small number of people in Calaveras. But it was overwhelming, if you would, voted yes to form the healthcare district. By forming the healthcare district, you now had the ability to access federal and state funds, as I said, and you also became part of a special district taxing formation. Most of you know that every county has special districts. There are thousands of special districts throughout California. In Calaveras, and they're like governments within the government. They're the tiny government. We're a tiny government. The 5 board members are elected. They have the ability then to hire people like me as administrators. They have their policies and procedures. They are subject to the Brown Act, the California Public Records Act. They are a government, a small government, within the government of Calaveras County. You have this all over. You have fire districts, water districts. I think there's like 20 or 25 special districts in Calaveras alone. They are additional government agencies, governments within the county government.
42, he said.
42, I didn't know exactly how many, because there's a bunch of school districts that I didn't count, but I was just looking at the list of fire districts, water districts, Calaveras Unified School District, Bret Harte High School District. All of them are different special districts. All of the special districts in Calaveras County do receive some tax dollars. There's a small percentage of the total tax dollars that are through an ad valorem tax methodology, and each year each special district gets an allocation from the county in 3 different payments. We got last year, we're going to get somewhere between $850,000 and $900,000 from the county of Calaveras to the healthcare district. Calaveras Unified School District, Bret Harte School District are the 2 largest that I know of allocation. Within the fire districts, I think Ebbets Pass Fire District is the largest that gets an allocation, but all of the special districts get some allocation, some larger and some smaller. Mark Twain Healthcare District is unique. Most healthcare districts take up a geographical boundary around usually a small city or a community or a region. But we're the whole county. So the Mark Twain Healthcare District is the entire county of Calaveras. And so it doesn't matter where you live in the county, when the vote comes around, you can vote for the healthcare district board. We don't have separate districts like the supervisors 1 through 5. It's at large, so it's voted on at large, but it's unusual to have this large of a healthcare district. Calaveras County is good size, as you know, but we only have, I think, between 45 and 48,000 people, somewhere around there. So we're spread out over a large area. As you know, we only have 1 incorporated city, and that's Angels Camp. So the healthcare district, that is where our growth went from there. I'm going to go now to a little bit more about the annual report. This is on our website. We're actually doing something a little different. We're trying, instead of printing an annual report that is maybe read or not, discarded immediately and then never seen again for another year, we've developed a series of ads that we rotate and print. We have 4 different ads that we're running right now, and then we print them at different times in different newspapers, etc., trying to get our word out. Mark Twain Healthcare District has contributed over $11 million in direct operational support to the Mark Twain Medical Center since inception of the lease in 1989. We continue to partner with the Mark Twain Medical Center in the expansion of healthcare services in Calaveras County In the past 5 years, the district has contributed over $400,000 to health-related programs, not necessarily hospital-based, and events that directly impact the health and wellness of Calaveras County. And 3 or 4 years ago, we established the annual Golden Health Awards, in which we try to honor some of the nonprofit agencies that provide health-related services throughout Calaveras County, and giving them a small token of our appreciation and a few dollars to help them in their operation and their programs. Our core values, we came up with access to health care, and we spell access through accountability, communication, collaboration, education, stewardship, and service. And we really would welcome you to come to our website and check out a little bit about who we are. This is one of the ads that we run. Again, it's a little bit about our visions and projects. What kind of things do we want to work with? When we do our goals and objectives, our primary focus is to work to maintain and support the hospital, and to make sure its programs and services are intact, and that we're providing quality health care, and to work with the Mark Twain Medical Center and Dignity Health for physician recruitment and retention. Because we recognize that without our physicians and other providers, and making sure they stay here and we're able to have their practice grow, we're going to be in a really difficult spot as far as services offered. We also work very closely with the Mark Twain Medical Center Foundation, and we have been working with them on several different projects, most recently in Angels Camp, but we do want them to be recognized as that primary spot for us to earn monies. History and evolution, talked a little bit already about the special election and what we were hoping to do that we do receive. We talked a little bit about the property tax that we receive. Who are we? Well, who's the face of the healthcare district? Well, this was our face up until also recently. And Dr. Peter Oliver recently resigned, and we're going to show another slide here in a moment that introduces Susan, our new board member. Healthcare districts, again, to go over this, are public entities. We are owned and run by the public. We're not private, we're not nonprofit, we are public entities. Totally subject to the Brown Act, totally the California Public Records Act. Public meetings like this was noticed, had to be put on our website, had to be posted in a public spot. We ran ads in the Union Democrat, the Calaveras Enterprise, and the Valley Springs newspaper regarding this meeting tonight. We are a public agency. Each of the California healthcare districts are governed by locally elected boards who are directly accountable to the communities they serve. So this is our board, also recently our board with Dr. Oliver resigning. How are healthcare districts born? How do hospitals born? How are they born? Within the healthcare district, I told you a little bit about the 1946 date. In 1990, we're going to be spending a lot of time talking about 89 and 90. In 1990, the Mark Twain Healthcare District negotiated what turned out to be a 30-year lease of the land and buildings in San Andreas with the Mark Twain St. Joseph Healthcare Corporation. So that was the first step in how this hospital continues to be. Secondly, comes the Mark Twain Medical Center, and this is a chronological of some of the things that have happened. 86 discussions began. You know what I didn't know until Bob Campana, who was one of the folks who were one of the original members of the district board that did this deal, told me that before they actually went with St. Joseph Stockton, they had about a year-long flirtation with Sutter Health, and I didn't know that. And so then I was looking up in some of the other documents that Larry Phillip and Gary Spa had provided me, and sure enough, there was this discussion about, so before they went with St. Joseph of Stockton in the late 80s, they spent about a year working with Sutter Health. For whatever reason, I don't know the reasons, and I couldn't really find much documentation regarding that, that relationship didn't flourish. It didn't survive that sort of year transition and discussion. And so those discussions were called off, or that relationship was called off, and the district board began to take a look to Stockton and Stockton St. Joseph. Now, Stockton St. Joseph at that time was a very fledgling, and it was just the beginning of when health systems were starting to grow and multiply and to do mergers and acquisitions. And so at the time of the discussion, Stockton St. Joseph was essentially a four-walls hospital, a standalone hospital, and I think they bought, was it Oak Park or Parks, what was the name of the?
Oak Park.
Oak Park, they bought Oak Park Hospital, which was a privately owned, physician-owned hospital, ended up closing that and opening a behavioral health, mental health hospital there, which I think still is in operations today. But they were a fledgling, just beginning health system. They weren't part of a larger system at that time. Mark Twain Hospital District board members began to have conversations with St. Joseph of Stockton, and they started looking for a model. Now, here's what's interesting. The model they chose ended up being a model used across the country with some different caveats, but it was a model that I've actually seen used with some of my other clients. And the model was, let's be a parent. So the Mark Twain Healthcare District is one parent, and the St. Joseph Stockton is the other parent, and they created a child, and it was called the Mark Twain St. Joseph Hospital Corporation. It was a 501c3, a nonprofit. So this public agency and another nonprofit agency, which is St. Joseph of Stockton, went together and created a new entity, a 501c3 called the Mark Twain St. Joseph Hospital Corporation. Today, it's called the Mark Twain Medical Center Corporate Board. But back then, it was the Mark Twain St. Joseph. They shared each name. And so they entered into a contract, a series of contracts, actually. Here, just a little. So they entered into these contracts. Now, we need to talk a little bit about why would they do that? Why did they do that in the first place? Because healthcare districts and small hospitals, while many of them flourish, as has this one at different times, always seem to have some struggles. And at the time in the late 80s, the Mark Twain Hospital District and Mark Twain Hospital was having significant financial cash flow issues. They were not able to fund depreciation, which means they didn't set aside any dollars for repairs, etc. And they had documented significant problems with both plumbing and electrical systems from the older hospital that was built in 1951. So they were having issues there. But as importantly, or maybe even more importantly, payroll. And inability to make payroll. Now, interesting enough, one of the district board members, Mr. Ken McIntyre, was a manager of a local bank at that time. He wasn't on the district board and he wasn't on the corporate board, but he managed a local bank. And he's told me stories of multiple times where the district and the district bank, at his bank, would come to the bank and say, we need some cash. We need some cash because some of our vendors, suppliers had put us on COD, cash on delivery, so they couldn't get supplies unless they had some cash, and multiple times they were at risk of not being able to make payroll. So the local bank would extend the dollars. Why would that happen? Because Chris in the back knows accounts receivable, dollars have to flow, and sometimes when you do your billings and whatever, for all the magic that happens, it takes a while for the money to come to the hospital. So these dollars were not flowing. And so there was a critical moment in the late 80s for the Mark Twain Hospital District and Mark Twain Hospital. And it's just simple cash flow. Utilization was good. There was no question about utilization, although there had been some question about decline in physician recruitment. It wasn't nearly as difficult to recruit physicians then, and certainly not nearly as expensive as it is now to recruit physicians. But utilization was pretty good. Payment wasn't necessarily great, although we did have some of the federal payers that are in place now were in place at that time, so it wasn't like we were still waiting for Medicare or something. There was something like that. So it just plain old cash flow. But also there was some shared commonality by working with Stockton and St. Joseph. People were leaving here to go there already in some numbers, not great numbers because it was the late 80s and travel is, the roads were whatever the roads conditions were. But there was some travel and outward migration to Stockton. So there was some logic to go with St. Joseph. Deals were cut, money was loaned, cash flow went away, cash flow issues went away, and some stability was brought back to the organization. The Mark Twain Healthcare District had given up its operational authority of the hospital. It had assigned the operational authority to the Mark Twain St. Joseph Corporate Board. Make sure I get the names right. The Mark Twain St. Joseph Corporate Board. Now here's where it gets really tricky. This is where some of the new contracts that came into view that are totally unique to my knowledge of any district really in California has quite as complicated and as sophisticated in some ways as we have here. Mark Twain Healthcare District gave up the operational authority, but two of its members appointed by the district would sit on the Mark Twain St. Joseph Board. And the board, the new operating board, governing board, was a 7-person board. So 2 district board members would sit on that board. And that's still true today. Lynn Reed and Ken McIntyre, members of the Mark Twain Healthcare District Board, sit on the Mark Twain Medical Center Corporate Board as voting members. In addition, the district was, through this contract negotiation between themselves and St. Joseph Stockton, could appoint 1 community member. And today that's still true. And Dr. Dave Wittens, a dentist, I believe he's a dentist, retired dentist, I think, sits on that board and has for many years. And so that's still in place. In addition, a member of the medical staff, and I don't know, Larry, is it always the chief of staff? Both Larrys might know that. Is it always the chief of staff or any physician that he might appoint could sit on the...
I think it's any position.
Dr.
It
Starr, do
happens.
you know that?
I think that's true.
Yeah, so there's a physician position on the board, and it's usually done by the chief of staff, but it doesn't have to be. I believe the chief of staff, he or she, could appoint a member of the medical staff to sit on the corporate board. Dr. Bill Griffin, who is chief of staff and radiologist here at the hospital, sits on the corporate board and is chair of the corporate board. So off they started, cash flow alleviated, and they started building back towards some normalcy of cash flow. And for a period of time, things went very, very well in that regard. Although it did not address immediately the deterioration of the older hospital, which is the area we're sitting in now, which has been totally remodeled in some areas. And this didn't exist at all, probably, Larry.
This was the ER.
This was the ER?
Yeah.
All right, so there you go. This was the ER of the old hospital. And so it's a very nice education center now, so I didn't know that. So anyway, this was the older hospital. And so there was some beginning, 1987, it talks about here, and in 2001, the Mark Twain St. Joseph entered into a management agreement which was with Catholic Healthcare West, and in 2012, Catholic Healthcare West changed its name to Dignity Health. So remember earlier on I talked about St. Joseph of Stockton was its own fledgling health system, but at some point it got consumed, like was the trend at that time. And so Stockton St. Joseph became a part of Catholic Healthcare West. Catholic Healthcare West in 2012 or 13, I'm not sure, it says 12 there, changed its name to Dignity Health, and in 13, Mark Twain St. Joseph Health Corporation changed its name to the Mark Twain Medical Center Corporate Board. So there's that evolution of how things happen. But okay, so what I told you doesn't sound that complicated, so they just created another intermediary, a 501c3. What's so complicated about that? That doesn't sound so complicated. Well, here's where it gets interesting. The craziness, the genius, Bob Campana and others, I don't know exactly how many people came up with the idea, but I know Bob was certainly a part of it. Said, well, yeah, the healthcare district is willing to give up operational authority, but we want still a slice of the pie. We still want a fiduciary interest in how in the outcome of the hospital, especially if it's positive. If it's not positive, I'm not so sure that's the case. But if it's positive, which we believe it will be, we'd like to have a piece of that pie, if you will. So the Mark Twain, the contract says that the assets, accumulated assets of the Mark Twain Medical Center Corporate Board, or the Mark Twain St. Joseph, that 501c3, as their assets grow, half of those assets are now owned by the Mark Twain Healthcare District, and the other half, who do you think? The other half is owned by St. Joseph of Stockton, Catholic Healthcare West, now Dignity. And they did that in a very clever way, in an interesting way, back in 1989, to protect St. Joseph for their investment and to protect Mark Twain Healthcare District to participate, to be a participant, long-term participant in the net assets. Now, there's a lady in this room who came here not that long after that deal, right, Kathy? Right. Were you came as CEO at that time? Correct. Right after the deal was done?
We were called administrators in those days.
Yeah, that's right. So Kathy came, Kathy Yarborough, if you don't know Kathy, Kathy came right after the deal and was here during a very interesting period of time, and also were the strong evaluation that while the 1951 hospital was a upgrade from the hospital up on the hill, the old two-story building, it was rapidly declining and needed a new infrastructure. And so Kathy was here during the time where the Mark Twain Medical Center floated some bonds, had a bond issue, public bond issue, and raised the money to build a new hospital, which we now have as you go down a series of steps down the hill, and you see the new hospital, which primarily has, they moved the emergency room from here, right, it was here, all the way to the other end, and a lovely lobby, a really nice lobby area for a small community hospital, cafeteria, radiology, surgery center, outpatient and inpatient surgery center. And so that created another opportunity for some logistics between the Mark Twain Medical Center Corporate Board and its, at that time, Catholic Healthcare West. So they sold bonds, and there's a guy who Larry knows, Gary Hicks, who is still working with the healthcare district. Gary Hicks is helping us do our financial arrangements for the New Valley Springs Clinic. Well, back in the day, Gary Hicks was here and assisted in doing the financials and getting the bonds for the new hospital. So bonds were passed, bondholders bought the bonds, money's exchanged hands, and the new hospital was built and opened. At some point after the hospital opened, the new hospital opened, Catholic Healthcare West decided to go out and refinance their whole organization and to look for better interest rates and to try to make things work a little bit better financially for their total corporation. When they did that, the people who sold the bonds and who organized them, from people like Gary Hicks and Bond Council and those folks, when they did that, the Catholic Healthcare West included Mark Twain Medical Center corporate board, the 501c3, the debt that they owed, they included it in the total debt of the corporation. And they refinanced the total debt, which then gave this organization a much lower interest rate because they were refinancing, that time probably 16 or 17 hospitals. I'm not exactly sure how many hospitals they redid all at once. But the net result of that was that the interest rate paid by the 501c3 Mark Twain Corporation, Medical Center Corporation, was lowered significantly, saving dollars. When that happened, that dollar savings goes to the bottom line, and then ultimately, again, go back to the old 50-50. If it goes to the bottom line, reserves grow, and half of that, 50% of that reserves goes to the healthcare district, 50% of the reserves go to the, went to Dignity Health or Catholic Healthcare West on paper. Now when we say it goes to, that's one of the parts I want to explain to you. Because when you look at, I just so happen to have audited financials. By the way, on our website are audited financials since 2009. If there's some night you can't sleep and you're thinking, boy, what would be more interesting than the audited financials of this organization? Well, this is where they are. And I'm going to take you to here. In 2014, our interest in Mark, I'm right here, interest in Mark Twain Medical Center was $19,773,286. At the end of 2015, in June, it's $19,828,531. So, 1990, we're broke, we have no money, and we're struggling with cash flow. 2015, 50% of the net assets of this organization add up to just under $20 million. So that's a calculation. Now, you said, well, wow, look at you guys are fast. We got $23,412. The problem is we can't touch it. We can't actually touch that $19,828,531 because it's essentially only available to us upon dissolution of the 501c3 that sits in the middle. And so at the end of the life of the 501c3, when it's dissolution, then that's when the 50-50 split takes place. So on our books, at the end of June 2015, sits $19,828,531. An identical number sits on Dignity Health's books, $19,828,531. Neither one of us actually can touch it. Now, what can we touch? By influence, political influence, and working with the boards, we could say, we could all agree to spend some of those assets on medical projects. Because of that $19,828,000, some of it's cash, is accounts receivable, right, Chris? Some of it's plant and operations, and some of it's investments, a portfolio. The portfolio is managed by something called Catholic Healthcare West Roman numeral 2. I have no clue, probably some offshore. That wasn't appropriate, was it? I didn't have to say
Let's
that.
not start.
I'm sure it's not offshore, it's probably Minnesota.
You're being videotaped.
It's somewhere, it's somewhere. And it's done very well over time. In 2009, our net assets were around 13 million. End of 2015, you can see we're around 20 million. However, as you know, many of us, not all of us, but many of us, Joe's not, he's not retirement age, but many of us are at retirement age and we know our portfolios go up and down, and so do our fortunes. And so since July 1st, 2015, through our last financials, which would have been would have been the April financial, no, the February financials, because we lagged a month and a half. We're down almost $2 million off of that $19 million and $17 million and something. That is primarily due to operational losses at the hospital and stock market portfolio losses. The combination of the two, is that about right, Chris?
Yes, it is.
And it's a couple million, right?
Yep.
So we're down to 17 million and something. But we're coming back. I saw the market was up today. So who knows? Anyway, so that's a little bit. So what makes us so unusual? Because we're coming to the end of our lease. We're 26 years into a 30-year lease, and we've got to make some decisions. And so we're starting to take a look at all the things we need in order before we can make good decisions about our future. That's why this thing is called the future of the Mark Twain Healthcare District. Because what will the healthcare district do? What should it do as the lease comes to an end? What kind of relationship should we have? We're very fortunate. Lynn Reed, our board chair, sits on the board of the Association of California Healthcare Districts. So she's very familiar. In fact, you're one of the officers this year. You're vice chair. Are you going to make the chair next year? No. Oh, you're done? You're turned out?
I am.
You and Willie Brown are gone? All right. So, but we have somebody right there in the ACHD, and we have a pretty good handle on what's happening with healthcare districts throughout the state. Those who are pure independent, those who are community-based, and those who are aligned with systems. So it's not like we don't have some information and some examples to draw from for the board to make decisions on. But really, up to the board, and then ultimately I'm going to talk about the next complication in this whole process, it's up to the people. When the deal was done, when the deal went down in 1989, 1990, there was no law that said the deal had to go to you, the people, for review. The district board made the deal because they were the governing body of the healthcare district, or the hospital district it was called. So when that deal was done, they did not need any advice or vote from the people. Today they do. In 1992 or 94, I keep saying 94, but then I got corrected the other day. It was actually 92, I think. Somebody told me. I think it's 94. Pretty good numbers. But anyway, the law changed and it says if you lease more than 50% of your assets, you must go to the vote of the people for approval. So, not only do we have one of the more interesting, complicated deals about a small hospital in a relatively small county, but in addition, we have a nuance to that is that the law now requires that the district board can come up with a plan. They can endorse a plan. They can send it to the county to have it placed on the ballot, and then you get to vote on whether you agree to it. Now, it's not like a parcel tax where it needs a 2/3 plus 1 vote. It's a simple majority plus 1, 50% plus 1 person vote, and if you get 50% plus 1, then whoever got that, if you get that, then that particular act passes. So one of the things that the healthcare district is doing, and one of the things that we'll be coming back to over, I'm looking at the time to see how I'm doing here, that we're going to come back to is, in our May meeting, is what is the process we're now in regards to looking at the lease and the future. It's a really complicated decision. It's not just easy. It's not just emotional. There's a lot of numbers to crunch, and there's a lot of conversation to have before you make that decision. Our attorney, a guy named Mike Dean, who works with Nave Meyer's law firm in Sacramento, has challenged the board to not make an emotional decision, because this is as big a decision that they're going to be making as what the board made 30 years ago. To really take a look at what you want to do, come up with the best plan that you can find, to look at the options that you have. One of the things the district board did was, as soon as we started this process, was to instruct me to get an independent operational viewpoint. What if the hospital or a healthcare district was independent? So we had a two-part presentation over a 3-month period by a consultant named Carl Gerlach. And Carl's been CFO and CEO in many healthcare districts all over California. And he basically looked at OSHPA data and other things. He didn't do a report specific to Mark Twain, because that wasn't what we asked him. We asked him to take a look and do a comparative. So he looked a lot at critical access hospitals. Oh, by the way, I didn't mention, we're a critical access hospital. That's another thing that we did that kind of made things interesting. Critical access hospitals are certain kind of hospitals who are in rural areas, frontier areas, and X number of miles away from another hospital. And if you are one of those critical access hospitals, then you have a different reimbursement rate from Medicare and Medicaid. It's based on cost. It's a cost plus, cost base, less and less plus the last few years, right? They're reducing the plus. A big reduction since the affordable, since the CARE Act went through, the ACA went through. But we're still getting our cost plus. So that's another factor in taking a look at what kind of hospital we have, because we're a critical access hospital. And then the other big piece is we're licensed as a what's called a GAC, General Acute Care Hospital, GACH. A General Acute Care Hospital says that you have a license to do certain things. And within that that you're okay within that license, and you must do those things. And the California Department of Public Health, they're the ones who oversee your license. They'll be checking on you about if you're doing those certain things. And as Kathy knows and Larry knows, they'll drop in on you at any time. In fact, they were here just, I think, last week or so that they dropped in. And a couple of weeks ago, we were surveyed by the Joint Commission. And they come every 3 years if you're lucky. If you don't do as well, they might come every 2 years. But I think this was a 3rd-year visit, right? Yes, you know exactly. You had read that charge. So we are at a critical point in our time. We're 26 years into a 30-year lease. We have important decisions to make, and there's many factors, multiples of factors that have to be considered. Financial, political, national politics. What is our status as a critical access hospital going forward? Dr. Smart asked us, and we did do a small program on I think it was called some critical access hospitals in critical condition or something. It was a study that we looked at of critical access hospitals across the United States. Oh, I didn't tell you the parameters. You have to be, for instance, what is it, 11 miles to Angels and another 18 or so over to Sonora. You have to be just over 30 miles from the next hospital to make this happen, and or have road conditions. Well, that's where you got a plus, because your road conditions are not great sometimes going between here and Sonora. Same with the hospital in Amador, Sutter Amador, going the other way. And then Lodi, of course, and Stockton and Modesto, they're all beyond that. So you're safe, it appears to me, as a critical access hospital based upon the current parameters of mileage and road conditions and weather that you might get, whether it be, I know you guys don't like to think you get snow, but you do, right? So as far as when we are applying for critical access, you get snow, absolutely. And so you have trees across the road, et cetera. And so there are conditions that keep us as a critical access hospital. So there's just a lot that has to be done to understand, but the history is so unique of what happened here. The, I think, bravery of the board 30 years ago, the due diligence and good efforts and partnering between St. Joseph Stockton and the hospital in the early days. And then, of course, as things evolved and changed, St. Joseph Stockton became, again, just to remind you, became part of the larger system, Catholic Healthcare West, and they didn't become a part of Dignity, they just changed their name to Dignity. But they continue to grow and to have hospitals. And when you go down in the lobby, you'll see many of the pictures of the hospitals that are aligned. I don't know if they're all down there, but a goodly number of the hospitals that are aligned with Dignity Health. So, I'm going to go back to one little area for just a second. Can I show the pictures of the board? I got to do that because one of them signs my check. I gotta make sure that happens. There she is, Lynn Reed. She signs my check. Ken McIntyre, treasurer, he signs my check too. I appreciate it both. And there's our new board member, Susan. Welcome. Susan came just in time for a very, very interesting. A little bit, if you want to go into here, a little bit more on our website under community resources about who we are and some of our history, and just so people understand that we do have a very active and very informative website that gives you a lot of information. There we go. So here's our annual report. Oh, and by the way, those of you, if you really want to spend some time reading, here's our HFS report. That is our one of the things that the board asked us to do as we were getting ready to go back up here. So on our website, under special report, one of the things the board asked me to do is to find a consultant to come in and look at fair market value. Healthcare district law says healthcare districts should get fair market value for their hospital. What the heck is fair market value anyway? For a hospital that's up in the Sierras, foothills, off by itself. What is the fair market value? I might know what the fair market value is of a store and a shopping center based upon other comparables, but how do you find the fair market value? So if you're really looking for something to read, dive into this, and it gives you 3 or 4 different models of evaluating what a fair market value is, and then you still might be scratching your head, because I am at times on it myself, but it is there. So let me see if I covered all the top of financials, the history, the board relations. So what happens next? The healthcare district, at our next meeting in May, we're going to hold another one of these. We are in what's called a non-disclosure agreement, NDA. Actually, it's called a confidential and non-disclosure agreement with Dignity Health at this time. The 2 members of our board, Dr. Randy Smart and Lynn Reed, represent the district board in what's called an ad hoc lease evaluation committee. The ad hoc lease evaluation committee, there are only 2 people on that committee. It's those 2. I provide staff support, as well as our attorney provides staff support. We are in a process of looking at numbers and ideas and thoughts regarding how might we move ahead. How might we move ahead? In addition, the board is looking at other options of what if the board chose not to move ahead, and were they ever going to look at independence. And like I told you before, we've already had 2 presentations by Mr. Gerlich, who looks at some of the, he calls them critical factors, and he has like 3 pages of critical factors for a small independent hospital going independent out of a system. He's got those critical factors, and he has some numbers tied to them, and some summaries there that are available for us to take a look at. And then, in theory, there is always the opportunity, and not in theory, in actuality, there's the opportunity for the district to say, you know what, we're going to go out with an RFP and talk to anybody and everybody, and that could happen. But for now, we've had 26 years of relationship with an organization. And for now, we are very much into that discussion. And so that's where we are right now. And next month, I anticipate that we'll be able to give a more up-to-date report of exactly what's happening in that discussion. There is some timeline urgency, not emergency, but urgency. We're not in an emergent situation. We're not cash poor. We're not going under. We're not closing, like some of the other, you read about other hospitals closing, etc. So it's not emergent. It's urgent if we want to put it on the ballot in November, because we have to have whatever comes from that conversation has to be available and endorsed or supported by the district board prior to, and then it gets sent over to the county, and then it's been put on the ballot for November of 2016. That has to happen in early July. That means by the end of June, when we have our regular board meeting, we meet on the 4th Wednesday of every month. And I know none of you have anything to do at 7:30 in the morning, so come on by. We'd love to have you here at 7:30 in the morning. We have coffee and juice, and sometimes great calaveras. What are those? I don't know what they do, how they cook the eggs here, but they're just delicious. They're just hard-boiled eggs, but they do a great job down in the kitchen here. They bring us up hard-boiled eggs, so we have those sometimes.
Over there?
Pardon?
The meeting's over there?
Right here, right
In
in
this
this
room?
room, right here in
Oh,
this
okay.
room. So Wednesdays, so by the end, whatever the 4th Wednesday in June is, that's why we're meeting regularly, every week. Lynn and Dr. Smart, they get together and discuss things, and on a regular basis, we get together with Dignity and talk about some of the issues. So that's moving along. And so it could be that in May we have something more to talk about. At this time, we can't really talk about any of that at this point, but we can talk about anything in tonight's meeting about the history. If you have questions from a board member or myself, or you want me to go through another version of how it happened, we could go to Larry Carlson, then we go to Larry Phillip, and then we go to Kathy, and we get their version of how it happened, how it really happened, and what really did happen. Kathy, you could tell us about, though, right now, just a little bit about the new hospital, because you were here. And was there like a community swelling to?
We started with a wonderful person by the name of Roger Ricalis. And what we did is imaging and envisioning with the staff and the board about what they saw in the future of the hospital and how we were going to get there. And we went outside and stood and talked about it, and people could actually feel and see the need and believe that it was possible to build a new hospital in this community. And so through a very, very extensive planning process and fund development that was, if I started naming names, I could forget people. But we raised about, I want to say $33,500,000 from the community in a tremendous fundraising. And the community came together, the community could see it, they could vision it, and we did it. Larry can tell you, we went to every community in this county, and some places that people probably never been, and talking about what kind of healthcare needs needed to have, and we were able to galvanize the community. But one of the things that I want to add is that it was not just this community, but it was the community that was provided by St. Joseph's. And St. Joseph's was very supportive. They were trusting. They were here for everything that we needed, and the relationship was built, as Bob Campana has said, and others that were on that district board. It was built over many meetings and many people coming together with a feeling of what needed to be best for this community and St. Joseph's. And it was built on a lot of trust. And it was really fun.
Yep, it was.
We had a lot of fun.
Great time.
It was a different time when we first started, and Larry was one of the first people that I hired. We really had only 3 doctors, And after 10
Wow.
years, when we opened this hospital, there were 32 doctors.
Wow.
And so we had tremendous support from St. Joseph's and the recruitment process and the community. When we recruited a doctor in those days, we had a meeting that included the bankers, the school principals, the people that ran the stores. And, you know, because we were recruiting physicians to a community, not to a hospital. And I think that's the key. And as we go forward in all of this, it's very important to realize it's a community. Calaveras is a very unique community with many unique problems right now. And we have to look at what's going to be best for this hospital, this community, to do what the district has done, and that's to provide access.
Larry, did you want to add anything to anything about your observation?
No, it was a great time for this community. I think this next step, with the lease renewal, if that's what happens, the community has to be a part of it.
Yep.
Not just from the voting, but from the emotional side of things. This is their hospital, and that's how come we're successful, is because this is the community's hospital. So it's going to be exciting.
So Larry Phillip over here, after Kathy, there was a gentleman named Mike Lawson, I think.
There are many.
And then there was an interim named Larry Phillip. And then there was another interim later on named Larry Phillip. It's the same guy. And now here he is again. Anything you wanted to say, Larry?
No, you've covered everything in the history very well, and certainly Kathy added to that. I felt really sorry for Kathy when she came up here as the first administrator under the new arrangement, because I think she spent about 120% of her time on the phone trying to convince vendors to deliver a product to this hospital and figure out how we're going to make payroll and all that. So a lot of things have happened in a positive sense. New hospital, latest in medical equipment here, and a great facility to care for patients. So a lot of hard work went into this by a lot of people, the medical staff, the community, the board, certainly both boards over that time. So yeah, we're at a point where it's hard for me to believe, since I was at St. Joe's in '74, and so I was there when all this happened. I wasn't intimately involved in negotiations. Gary Spa, deja vu all over for him again, because he was involved along with Ed Schroeder at the very beginning. So it's fun to be back here to see the end point is coming in terms of the 30 years going by. So anyway, you did a great job covering the history from my perspective. The hospital was in trouble in the mid-'80s, so, and it obviously recovered extremely well.
Thanks, Larry. Dr. Smart, your mother was on the board for many of the years of that transition.
Years and years.
Years and years, and
Many
you probably missed dinner.
Many dinners interrupted by phone calls.
Yeah.
And floor plans and blueprints and things where she would run out of the house and we'd say, what about dinner? Years and years.
Anything you wanted to say tonight in regards to, I'm going to go to each of the board members and see if they want to have any comments at this point.
Well,
Then we're going to ask.
the only, I thought the history is great, thank you. I think the thing I would say is we should be really grateful for what those folks did 30 years ago, 25 years ago. It's great to be in a position where we have choices rather than being bankrupt and begging for help. What we do, and it's probably not going to even be in the next 30 years, but what we do in the next 10 years is something we're taking really seriously. We're really trying to understand what the options are. And, you know, it is so complex because healthcare in this entire country is in turmoil. And so to try to figure out what is healthcare going to look like in 2025, nobody can tell us that. And so it's a challenge for us. We're taking it really seriously. We're trying to do our homework. We've got great consultants, but ultimately what Kathy said is right. This is a community hospital. This is our hospital. And you, all of you and your neighbors and all of Carol Averis really have a voice in this. And we need to hear your voice. Because we represent you. You elect us. You trust us. And we need to know what you think, and we need you to participate. And whatever we do, we'll need you to even participate more. This is a hospital the community has to use and has to trust. It won't survive without community participation. It just won't. So be part of this process. If you are, because you're here tonight, but our board meetings, we listen. We talk to people on the phone, we listen to their board meetings, and we want it to be a community hospital, and we want to know what you think. That's what I would say.
Thank you. Ned, did you want to?
And I would just add, Paul said Randy and Kathy as well, and I would just add to, those of you who are here to tell your friends and neighbors about what's going on. Encourage them to be active and paying attention. If they have the time and ability to attend meetings or go on the website, if they ever have any questions, they can email. All the board members are listed on the website. We have a phone number. We have an office. A few years back, we didn't have any of those things. But we definitely want input, feedback from the community, and we actually moved all of these meetings up because we just felt so strongly after our last board meeting that we wanted to get the word out about who we are and what we do in a hopefully a more broad-based way. All of our meetings are in the morning, so we thought maybe we could get some more folks to come at night, people who work and have other things to do during the day. So please just encourage people to, again, this is our hospital, this is our community, this is our hospital, and we want as much input as we can get from folks. In addition to encourage people, if we do end up on the ballot, encourage them to vote.
From the foundation.
Question.
Yes, sir.
Question. No, thank you for explaining the different entities and how they are related, or various ways. I didn't understand how or who is responsible for the various satellite care facilities that are going to be built in the next several years. Valley Springs or Angels Camp,
Sure.
who's responsible for that, and how does that get paid for? And who
Sure.
pays for that?
So the clinics are going to be licensed to the Mark Twain Medical Center Corporation. The Mark Twain Medical Center Corporate Board, the 501c3, holds the license in the eyes of the state of California. And those clinics are licensed then, the way its current structure as rural health clinics or specialty clinics, they will be licensed to the 501c3 as it's structured right now. However, the Valley Springs Clinic is a project spearheaded primarily by the Mark Twain Healthcare District, and they have secured a USDA loan to build the building. They used their reserves, the Mark Twain Healthcare District reserves, to buy the land, the 14.44 acres on the corner there of Highway 26 and Vista del Lago. So they own the land free and clear, and they are, through a loan, not a gift, not a grant, a loan, USDA loan, but a very low interest loan, will be building the building. They in turn then will need to lease it to the Mark Twain Medical Center Corporation, the 501c3. And that lease then creates the connectivity for the license. So that's Valley Springs. Angels Camp's a little different. Angels Camp will be a project entirely of the Mark Twain Medical Center Foundation, of which you're familiar, foundation, and also with the Mark Twain Medical Center Corporation. The corporation, again, will own the building. They will own the grounds, the operations. They were assisted in buying the land and building the building by the foundation. We are working collaboratively together on design. So the design of the Angels Camp building will look a lot like the one in Valley Springs. I don't know if they'll be identical, but they'll look a lot alike. And so we're working together on that to try to reduce some costs and to make sure that the building represents the needs as the hospital understands them, meaning the right number of exam rooms, the right number of radiology, the right physical therapy. And so we're going to have a very similar looking buildings. So both of the clinics, as are the 5 existing clinics. Now the 2 new clinics will replace 2 older clinics. So we would still have a net of 5 clinics if both get built at the same time. So you would still have the 5. So the new clinic in Angels Camp would replace the existing in Angels Camp. The new clinic in Valley Springs would replace the existing Valley Springs. So the net number of clinics would still be 5. Of those kind of clinics would still be 5. Arnold, Angels Camp, Copper, Valley Springs, and San Andreas. So that's how it's structured at this point. Part of it is, like I say, through federal dollars, a loan from the feds, U.S. Department of Agriculture. I know it sounds strange, but USDA builds many, many, many healthcare facilities across the United States. And they build lots of other kind of buildings also. USDA built, Malone built the, what's the new building out there by the food bank?
CCWD.
Yeah, CCWD. They're building, that's a USDA loan building. Pat Van Lee, who just shouted out right there, is our project manager for Valley Springs, and he's done multiple USDA loan projects, and they were school buildings, right? School districts use
A lot of Department of State architect buildings, yeah.
Yeah. So USDA is a good source of money for rural America and for both healthcare, education, and other services. Does that answer your question?
It does. Now, does Dignity Health, do they help run these clinics?
Yes, because they currently have a management agreement
Yes.
to manage the hospital, to manage the Mark Twain Medical Center. So they would, yes, definitely be involved in the management. In the current arrangement, they would definitely be involved in that.
And so when we look towards the future, whoever is chosen to work with the healthcare district is going to be involved in all of those clinics.
Exactly.
Okay.
Yeah, those clinics are an asset of the 501c3, that middle 501c3. Susan, I know you just got here a couple of months, and then we're putting you on the spot, but do you want to say anything about what you're seeing so far and what you're...
I guess first of all, I would just really like to thank you for an excellent presentation.
Oh,
And
yes.
I'm glad that this is being filmed for others that may not be able to be here tonight, so it'll be available to people. The other thing is that I've joined the group here at a very interesting time, a very busy time, but it's exciting. It's going to form the future of our healthcare district for some years to come, and looking ahead to see what people need and what's best for our community as a whole. And it's a large community because it encompasses our complete, our entire district and our entire blanking on the word county. Thank you. The other thing is, I know that the rumors have already started out there. I see them in the paper. I hear people talking. A lot of people have opinions about, well, just do it yourself. We don't need anybody to help us, or lots of opinions one way or the other. And I would encourage people to share their thoughts with us and to come to the board meetings and to contact us one way or another to share those thoughts and actually get some factual information to go along with the opinions that are floating freely out there, and be a part of the whole decision-making process, so that we can do the best job for everyone in the county.
How about you folks? Are there any questions from anybody? Yes, sir, Dan.
Yeah, Dan Lewis from Angels Camp, and just, I don't know if it's the right time to ask the question, but as you explained earlier about the foundation, there's a difference in the way that Valley Springs is owned versus Angels Camp
Yes.
will be owned. And
Yes.
why is that?
A couple of reasons, actually. One was the funding available, how much funding was there available. The other was the availability of funding from the USDA at a certain time, based upon their annual year and what we thought we could get at that time. And the healthcare district has some collateral, and so we made the decision, the board made the decision to go forward, and that the district would buy the land and build the building and own the project in Valley Springs, and that we would then lease back the building to the Mark Twain Medical Center. There had already been a long history, multiple year history, of fundraising and ownership of the Angels Camp project by the Mark Twain Medical Center and the foundation. And it seemed like it would be best for us to, I know you all remember Dogtown and our efforts at Dogtown. And so after that didn't go as well as might have hoped, the decision was made, let's take a look at where are the two highest needs in this area. And so we looked at Valley Springs, and about 1/3 of the people who live in the county live in that region, and a large number of folks who are still working and commuting into the valley live in that region. And somebody from education is probably here, but a large number of the elementary school kids in the county live in that region. So we were thinking, where can we put, and really the enhancement of the family center, family practice, really help the hospital, the community right now, and not have to wait another round of building Angels Camp, then going through a funding drive, and then be many years down the road. So part of it, I guess, would say was just the availability of the right time and the funding and the leverage of the district at the time. And so there are two models. You're exactly right. You're both right. There's the model that had been in place for many years to build the Angels Camp project, and then the model that evolved around the Valley Springs project.
One of the things we were concerned about is competition on our borders. And the west side of the county, that's an issue. And we wanted to make sure we had a strong footprint there.
Any other questions? Yes.
So the board will put together, I mean, they had a ballot initiative, it will go on the ballot, and what happens if the 50% plus doesn't pass?
So it's not a given that there will be a ballot initiative. If it makes the November election, it has to be done in June and presented to the county in July. But going back to the premise, let's say it happens. So the board will bring to a public meeting in June an initiative that they would either move forward to the county or not. It's not a given that they would, but they're going to be in a strong public discussion, maybe more than one, in regards to that process. If it goes to the county and it fails, nothing happens. The lease that's in place continues. And it doesn't expire. Maybe I didn't even say that. The lease goes until December 2019, December 30th, 2019. On January 1st, 2020 is the new day. But the last day of the lease is December 30th, 2019. So if the referendum doesn't pass, say it gets 42% or 36% or 49.99, if it doesn't pass, nothing changes. The old lease is still in place. If the board doesn't put a referendum on the ballot because they don't come to a consensus or a vote that they want to, nothing changes. The old lease is in place. It would continue on. One of the reasons we're starting this process now is that to give plenty of time for discussion. And let's say there's a referendum and it fails, and you want to have time to rework it, fix what didn't work, and take it out again before the end of a lease. Pretty common strategy to start this process 3 or 4 years in advance, and that's what we're doing. is starting the strategy in advance. So if for some reason it doesn't pass, there's always an opportunity. And another thing I failed to mention, we're not locked into general elections. Healthcare districts, like every special district, can have its own election, its own special district election. You have to pay for the whole thing then. You can even do it by mail, and it's commonly done in healthcare districts where mosquito abatement districts, water districts, fire districts will have a special election to raise funds for that entity, and they do it through the mail ballot, through the U.S. mail, rather than waiting for a general election. So we have all those same options. We can do it multiple times in theory. Typically, you do it twice, you probably, if you get no both times, you probably the answer is no. But
The other question you may ask is, let's say we get to 2019 without a solution, the lease we have right now cannot be extended. By law, we can't say, how about another 5 years, or we need a little more time. In 2019, we cannot extend it any further than it is. We have to do something.
exactly, thank you, that's a good point. California restricts public agencies to 30-year leases. Can't go beyond 30, can't extend beyond 30 years. You have to go out for a new lease. We actually got grandfathered. Remember when I told you about the law change and you had to go to a vote? They allowed us through the grandfathering process because our lease took place in 1989-90. They said, you can continue this lease, but you cannot do anything beyond the extensions of that lease. You have to go out for a new lease. Then, of course, the 30 years kicks in anyway, so it's two things, two mechanisms that forces us to go out for an election, should we look for a new lease. But, and I think, just to reiterate, at the end of 2019, if we don't have some transitional arrangement, then you really need to start transitioning at least 1 year in advance, because it takes a while. Because if you transition from the current corporation to the healthcare district, then all the employees of the hospital are employees of the current corporation. And so you have to transition all of that and everything that goes with HR and leases and equipment, etc. So you need to start a year or so in advance, which is doable. It's doable. Other people have done it. It's doable. It's not fun, right? Because it's a lot of work and expensive. Any other questions? Any other questions or comments? Mary?
I'd just like to know how many people are here because they saw the ad versus you're just connected to the hospital, so you heard about it through
good
email
question,
and
thank
stuff.
Oh, so we had some ads. We're trying to figure out if ads are working or, if some people are looking at it, we saw them.
Well, that had been running to mymotherbook.com, or we're on the radio, in the silver stations. So I just happened to see it. So we came out because we wanted to cover this. This is very important and very exciting. So my question is, you obviously have time. You have lots of time. Maybe not lots of time, relatively speaking, but you're thinking this out from lots of different angles. And the next month meeting, like, I don't know, this doesn't even necessarily compare, but when they're talking about the wagon trail, Caltrans and the local council governments, they have options or alternatives. I know you have to dance with your partner and figure out, this is something we both want to continue, this is working for both of us. Would you know in the short term that if Jamie is like, well, we kind of like to, move our assets. I don't know what your relationship is.
Yeah.
But in terms of would you know maybe next month, how options might be looking,
I think it would be fair to say that the committee, the two board members, we meet regularly, and our goal is to have not necessarily a decision, but a clarity about the process in May, and then to decide whether or not to bring to the board a possible referendum that could go to the vote in June. So here it is, mid-April. So a month from now, it wouldn't surprise me, we had a better understanding of that being a possible or not.
So you have more of a shape of how things might go.
I think we can say that. Yeah.
You can say that, pretty sure.
Well, it's probably because in fact, that's what I would think. That is.
Well, you'd be surprised. There's actually many issues that have to be discussed and many elements of the current relationship that might not be acceptable to either side. And they both want to change, but what would it look like if the change came about? But I'm kind of oozing over into next month's presentation. But I hear what you're saying.
Well, actually, I'm a little bit skeptical because
Yeah, that's all right.
I've spent a career doing that.
Yeah.
And a part of the argument is that there are a lot of complexities, and you're stating that there are a lot of complexities. And with those number of complexities, the likelihood of getting two people brought up to speed, written down, presented to the public well enough in 8 weeks to be able to garner
Yeah.
support, it doesn't sound.
Pretty ambitious,
Doesn't
huh?
seem feasible.
Yeah.
So you either know more now, which undoubtedly you do, or getting to a referendum in June is very practical.
Yeah, I get what you're saying.
Proposing to.
Yeah.
It's just that it's just a
If
skeptical
we,
side.
yeah, if we had an option for the November election to say to the county, you know, we're not really gonna know till September, and we have more time, that would be nice. But the truth of it is, you have to, early July, you have to turn it over to the county, because the way it works is the Board of Supervisors then through a consent calendar process, place those referendums that have been put forth on the ballot. And they have to go on the ballot, they have to be solidified by mid-July. So it's a timeline that we don't control. And so if we're going to make the November general election, we have to do that. That's the pace we have to work at. And you're right, every single day there's at least some kind of conversation, thought, or something that happens trying to make it, move it forward. It's aggressive.
What, do we know, do you know what the agenda is for the next 2 meetings?
The district agenda?
No, the meetings for May and June.
Oh.
These meetings.
Meeting 2, where are we in the evaluation phase of a new lease?
Okay.
And then recap and update of the lease process. So I don't know where it's going to be. I'd like to do it in this room, but I'm not, if we're actually going to talk about elements of the new lease, this room may not be large enough. I don't know. It worked today, worked tonight, and so it might be here. So you asked me, do I know where and when? No, we didn't set a date yet. And we're kind of interested to see how this meeting went and how it was received. But the next meeting is, where are we in the evaluation phase of a new lease? So we won't be talking about history. We'll be talking about now. Where are we? What has been done? What can we talk about? Exactly what have we done so far? And then the third thing is recap and update of the lease process. That was in June, and the intent was that would be, if we have a document, then we're totally public and everybody gets to take a look at it. All the non-disclosure agreement is no longer in place because we have an agreement to share in the public. And so then that's that kind of conversation. If we're not there, we didn't make it, and we're not going to make the November 2016 ballot.
I would be good, but you could just go ahead and do a mail ballot. So I mean, it sort of takes the pressure off, but we could certainly get much more participation with the November ballot.
Yeah, and there's, the experts, Lynn went to a conference the other day, and the debate about whether this kind of event would be good to hold in a general election such as the high-profile one that we're probably going to have. Is that a good place to be? What were their thoughts, Lynn?
Well, prior to hearing what the experts said, I just assumed, as most of us did, that you know, this is the best time because you're gonna get greater voter turnout because it's a presidential election. However, because of the complexity with some of the changes with the ability for the referendums, there's an anticipation of a significant number of referendums to be on ballot. And so there's all these studies that have been done about, you know, how many people vote for, how many actually vote, and how many people skip. And apparently there's a percentage that skip like every third referendum. They vote for the major election up top, you know, the presidential election. And then when you get to the bottom, you begin to lose 5% of the voters with like every 3 items. And anything local is at the bottom. And I thought, oh my gosh, here I thought we'd have all this great turnout if we end up being on the ballot. So it just changes the dynamic pretty drastically. Does that mean that's what would happen in Calaveras County? I don't know, but it's very complex. So they didn't really come out and say, yes, you should have something on this, you know, ballot or not. It's just that it's a lot more complex in terms of how many people might actually vote for the and of course you have no control over seeing it till it actually comes out. It's not like you can say, can you put me number 1? You know, we want to be at the top of the ballot so people vote on it.
Any other questions or comments?
Just
Yes, ma'am.
a clarification. On the, you mentioned the confidentiality agreement.
Yes, sir.
And there is a fixed time on that. Is that right? Or is that, do I recall?
There's an
that
extended
correctly?
time, but either party can cancel the NDA with notice, 60-day notice. So if it's not working, we can mutually agree to call it off. Or one side can say, it's not working for us, we're giving 60 days notice, we're done.
How long is there a fixed time on how long it runs?
Oh,
now?
the maximum it could go is a year.
Okay.
But
There's also a clause recognizing the Public Records Act.
yeah, the maximum it could go though is a year. It would, I can't imagine that.
Yeah.
Yeah. Any other questions?
Just one more question.
Sure.
In the upcoming meetings, is there an intention, because it's not obvious to me by the description, where the general public is going to get either a summary of the pros and cons that have been assessed, and if there is a recommendation on the part of this board, when is that going to, how is that going to get presented? Will it be presented to
Yes.
the general public?
So this meeting here is anticipated, meeting number 2, to be in May. That's in addition to our regular board meeting in May. So there's 2 board meetings in May, and there's an opportunity in May. And then the 3rd meeting is to be in June. That's in addition to our regular meeting in June. So in May and June, there are 4 public meetings. Now, the question, when will it be, if there is an agreement or a proposed agreement? If there is a proposed agreement, as soon as there is one, it will be brought out into public at one of those meetings. And so will that be the 3rd meeting, the 2nd meeting of May, and then we have 2 meetings in June to have more conversation about it? I don't know, because it depends on the progress that's made. And as you said, that's a pretty aggressive pace to get that kind of deal done. But we're working on it to make it happen, if it can happen.
And you expect that it'll be with the pros and the cons, the advantages, the disadvantages, the
Oh, yeah.
community, that'll all be discussed. in as
Oh,
much
yeah.
detail as the
I suspect there will be many views. We will certainly lay out the ideas that were, if there is a proposal brought forward, why it was being brought forward, and the merits, and pros and cons. There will be others who create their own, because they'll look at it and say, no,
Sure.
and so there'll be plenty of that, I'm sure.
Because I think that's what's most important, in my opinion, to get people to care about any referendum. Or are they going to, do they know about this? What does it mean to them? And oh, by the way, they just might be looking for it on the ballot when they get to it, if they know about it.
I suspect between the press, radio, and others, it's going to be pretty high profile. should it move forward. And there'll be plenty of discussion, so I think people will be looking for that. I think that is the truth, but it is going to be a very busy ballot. But I'm not so concerned about that as much as getting the work done from the committee, and that we're ready to actually have a product, if you would, to bring to the people to review. But again, it's not a fire sale. It's not like we have to do it in the next 3 months or it's all over. We want to do a thoughtful process. Any other questions or comments? Wow, thank you. It's 10 minutes after 8. We almost made it. We almost made 8 o'clock.
Thank you. Good job.
Thank you.